patient and your management? You bet. Because it's compressing his L5 nerve root. Well, what's the consequence of that? Everything. His gait or her gait will be off. Compensatory mechanisms to compensate for lack of sensation and firing of the appropriate muscles will come into play. So let's put all this together now with stem cell therapy. What I'm going to be talking about is a study that we participated in, or actually did, and it utilizes only mesenchymal stem cells, as Dr. Centeno has talked about before. They differentiate into muscle, cartilage, and tendon. This is what inspired the initial work. Saki, in the animal model, demonstrated regeneration of the lumbar intervertebral disc with the injection of cells. 2005, inspirational. We thought, aha, we've got it. We'll do the IRB and move forward. So our initial trial utilized the same protocol except in the human model. We utilized a bone marrow aspirate, BMA, and then we injected it under fluoroscopic guidance into the intervertebral disc. We were ready for publications and phone calls. Never happened. It was a spectacular failure. We scratched our heads, we stayed up late at night, but it was a failure. No one got better. Well, why didn't they get better? A couple reasons. Saki looked at an animal, which is a quadruped, walks on all fours. I don't have that luxury. I've got to stand up all day with lead. Saki also utilized a puncture model, which is an acute injury, whereas in the humans, lumbar degenerative disc disease is a chronic phenomenon. But equally important, with this bone marrow concentrate, BMAC, all it is isolating the cells and injecting them back. So as Dr. Centeno had previously discussed, we didn't have the sufficient number of cells for repair. So we went back to the drawing board. We had a revised protocol. We utilized a prospective case series. We did obtain IRB approval. We established inclusion and exclusion criteria. Patient had to have 75% of disc height. They had to have an intact annulus, no herniations. The exclusion criteria, they couldn't have any active neurologic or connective or inflammatory processes going on. They couldn't have certain meds, which excluded them. Here's the study, and I'll take a minute to talk about it. But what we used was autologous, which is a patient's own stem cells. Conditioned, we kind of put them in a special soup, so to speak. But most importantly, we expanded them. We expanded them because we had learned back here with the BMAC that we couldn't get enough cells. So now we expanded them. 12 to 14 days, state-of-the-art lab. Then we implanted them. We put them in the posterior annulus. I tend to use the analogy with my patients that first we till the soil like a farmer, then we put the seeds in the ground, those are the cells, and then we use fertilizer. The fertilizer is a platelet-derived supernatant.
Go back a slide. What is that tool in the upper right-hand side?
Something that caught my eye on the internet. I thought it was just a pretty picture. Yes. Eh? Correct, and we'll get to that. Thank you very much. Data collection. We obtained baseline laboratory values. We obtained, prior to the procedure, functional rating index, VAS pain scores, imaging studies, which were critical. As Dr. Centeno had previously talked about, we used the very best MRI, best in terms of the quality of the image. I didn't know much about MRIs until the last couple of years. And I'm just going to take a minute for those that don't know. An open MRI is terrible. A 0.5 magnet or Tesla is almost as bad. Then it's 1.5, and then 3. 3 is crystal clear. So if you can think of a magnet as like a diamond, no one wants really a half a carat. They want a 3-carat diamond. Same with an MRI. It's one of the best pictures money can buy. That's the baseline that we had. In the Denver Boulder area, we have the privilege of having 3 of these magnets. Equally important, we use specific slices with the stir and gradient recall echo with matching TR and TEs. Now, we did these before the procedure. We did them 1 month after the procedure, 6 months, and equally important, there is some diurnal variation. Once again, there is diurnal variation, so we had all of our patients scanned within 2 hours of the original study, so as to not have that factor. Then let's talk about the process. Patients undergo a bone marrow aspirate under fluoroscopic guidance. For those physicians in the room, I don't know about your hem-onc experience, but mine was pretty miserable, and so were the patients that had to endure my bone marrows. But under X-ray, it's a totally different game. We initially started doing it with anesthesia, but that's not required. One day the anesthesia provider didn't show up, so we never invited them back. And 96% of our patients have no complaint. So with 20 cc's of local anesthetic, a bone marrow aspirating 60 cc's is very possible. Then what do? We send off the bone marrow aspirate to a state-of-the-art lab in Colorado. You've already heard the different certifications. I won't bore you with that. Then, rather than use BMAC, we're going to expand those cells to get them to the critical number that's needed. At the same time, the patient donates some blood, which is then concentrated down to platelet-rich plasma. The platelet-rich plasma is then put in a daiquiri machine, spun down to make platelet lysate. And it's that very platelet lysate that is the fertilizer that grows the patient's cells. There's no artificial chemicals. There's no growth hormone. There are no steroids. We utilize a patient's own blood to grow their cells. We also use PRP. Martineau described a very elegant study in which calcium and thrombin were utilized to have a high expression for vascular endothelial growth factor. In English, what's that mean? It means we got a very rich soup that would give rise to angiogenesis, creation of new blood vessels. So this is our home screen, or one of my home screens. These are mesenchymal stem cells from our lab. They're beautiful. Not quite like an SI catalog, but you can see that they're spindle-shaped. They're all homologous. And this is what you see, and we continue to grow them for 12 to 14 days. Let's talk about, now we've obtained them, we've grown them, it's time to put them back in. We use a standard transpedicular approach. This is a caricature of a lumbar spine. There are 2 components of the intervertebral disc, the nucleus pulposus and the annulus fibrosus. I wish the annular fibrosis were this generous. It is not. I use this only for illustration purposes. A transpedicular approach, under intermittent fluoroscopy, we come between here, avoid the nerve root, go into the disc. That's a transpedicular approach. We implant into the posterior annulus. The reason being, the literature to date has demonstrated that this is a fairly hostile, non-vascular environment, which most likely could not sustain cell growth, as opposed to the annulus, which is vascular. after we deploy